Okay, so we're going to cover chapter 38, and primarily what we're dealing with in chapter 38 is learning about what a physical exam is, the purpose of it, the different aspects and components to a physical exam, the different examination methods, and what a physician or clinician is looking for while they're doing that exam. Um, we'll also talk about different body positions. Um, as well as draping while those patients are in the nine common positions that the book discusses. We'll talk about some safety precautions when you're actually putting the patient into the general or during that general exam, some of the safety precautions that are associated with it. We'll look at some kind of important aspects and techniques as far as assisting patients from different cultures. It definitely is a common occurrence, or patients that have physical disabilities. Those are always things that we have to look at and deal with, as well as follow-up. When we're looking at the medical assistant's role, um, you're basically involved with the patient care from the beginning to the end. You see them when they first come in, you get vital signs, you get an interview. You may or may not need to help physician assist with an exam um, during the actual physical exam process, and then you'll be dealing with them in a discharge fashion and scheduling follow-up appointments and giving them their discharge instructions. So basically, the medical assistants are involved from the beginning to end. And it is important to realize that medical assistants function not only to help the physician, but also to be an advocate for the patient, okay, and to help assist the patient any way necessary. Okay, so the first thing we look at um, as far as what we're dealing with in this chapter, um, the primary thing here is physical exam. Now, we covered the history in chapter 36, and really and truly, the physical exam is a second step in making a diagnosis or treatment as far as that process goes. The first step is a thorough history or a thorough interview that's usually done in the beginning part of the patient encounter. So the physical exam is kind of looking at what the history is and doing a guided physical according to what those symptoms have given. But when we're actually looking at a physical exam, a lot of times we're looking at that patient from head to toe. Okay, everything from a skin exam all the way to an abdominal exam. So you're going from the beginning to the end to try to do as thorough an exam on that patient's health as possible. Okay. And so the medical assistant basically functions to make the patient comfortable, okay, be an advocate, and also help assist the physician in certain case scenarios, okay. And so it's really up to the medical assistant to make the patient feel comfortable and also create an atmosphere that is positive. I mean, that goes along with the clinician as well, but the two working together to make that patient feel important and like their privacy needs are being met, as well as any questions they may have are addressed by both the clinician and the medical assistant at the end. So now we look at the purpose of a general physical exam. Basically, we're looking to confirm an overall state of health and provide basic baseline values. That could be lab tests, maybe it's even certain things like a chest x-ray, an EKG, but you're looking at trying to establish and look for that patient's risk factor for certain disease processes, and then do certain labs and x-rays and what have you to verify that and to actually discover if there is anything going on, okay? So we're looking at either confirming an overall state of health or diagnosing some sort of medical problem. Okay, so some people come in with a problem, or they'll come in for a physical exam and then say, well, I'm having this issue and that issue as well. And so then it would be confirming the overall state of health as well as looking into whatever medical problems they have at that particular time. You're going to have to, after getting a history and then performing a full physical exam, you then come to a clinical diagnosis. Okay, and we've kind of talked about these already a little bit, but it comes back here because we're dealing with the physical exam itself. Remember, we have signs that are objective things that we can actually ask and measure. Okay, those are listed in the objective part. But then during our interview process, we're getting all the patient's symptoms, and those are subjective, whatever the patient is reporting. Okay. The laboratory and diagnostic tests go under the objective part, okay? You're going to do things that are gauged towards trying to either confirm or rule out whatever the clinical diagnosis is. Okay, if it's a physical exam, then generally you'll be doing a baseline of um, cholesterol, blood sugar, kidney, liver, um, overall health issues to see if there's any problems, and then you base that on any information from the history or physical that might deem checking certain things. Okay, so those laboratory tests work together to kind of rule out or at least confirm a diagnosis or rule something out. And remember, the word differential diagnosis means that if we've got a case scenario where someone has a problem and we're trying to rule out more than one thing, or we're not sure what it is and trying to rule out between two things, you'll get something called a differential diagnosis. Okay. Prognosis isn't always given. It's prognosticating um, what the actual outcome of a disease process is. So not every single visit is going to have a prognosis. That's usually reserved for more chronic illnesses like cancer or diabetes, or something that is going to be a long-term chronic illness. At the end, you'll come together and form an assessment or a diagnosis, and then there'll be a treatment plan depending on the case scenario. Some treatment plans are very short. Other treatment plans might be quite extensive, involving follow-up care, imaging, labs, referrals, possible medication, and then usually a follow-up visit as well. Okay, so when we actually focus on the role of the medical assistant, we're looking at, as I've said before, a dual role. You're looking at being able to assist the licensed practitioner or the clinician during the exam, as well as the patient. If the patient needs to be helped into a different position, if the patient's nervous or scared, you might even just sit and hold that patient's hand while the doctor's doing the exam or the clinician's doing the exam. Okay, and so those are all important factors for the medical assistant, but there may be case scenarios where you actually have to hand certain things to the to the clinician, certain instruments, and so that's also a possibility as well. Um, the whole entire the whole entire purpose of the visit begins as the patient enters in and sees the receptionist, or that receptionist might actually even be a medical assistant. Okay, so things begin before the physical exam. Okay, we have the interview. Okay, we've discussed that in chapter 36. We have to make sure that that history is accurate, and once again, there are times where the patient doesn't always open up completely to the medical assistant, but it's important to establish that trust, have a good rapport, so that you have a higher likelihood of giving accurate information in your interview and your history. Okay, then you'll be determining your vital signs, making sure that all of those are documented, and even though they are documented in the beginning part of the interview, technically they are still part of the objective. Okay. And remember, pain can, if you're in a physical exam situation and that person's not reporting pain, then it would be something that you would ask as a fifth vital sign. If there's an issue where they are having low back pain or some sort of pain, you would then include that pain assessment or that pain evaluation in your history of present illness. Okay, and then we measure height and weight. And remember, those measurements are part of the vital signs, even though they actually aren't vital signs themselves. Okay. Responsibilities, this is going to generally be something that you're going to do before you see the patient. That's why you need to have an idea of what the patient's visit is designed for. You have to ensure that instruments and supplies are available and ready and in stock, so to speak. Okay, you don't want to have the patient ask some more questions, decide to go looking for something, and not have the available instruments necessary. So you always want to make sure you over-guess and have things available in case they're needed, so the clinician's not rummaging through the room or having to leave the room to get what they need. Okay. You also want to ensure that the patient is comfortable. Don't ever stick them in a precarious position and then leave the room and not know exactly how long the clinician is actually going to be. We'll talk about this in class as well. because you will help assist in the positions, but you want to make sure you let the patient know why you're putting in that position. And you also want to make sure that you don't leave them in an uncomfortable position for a long period of time. Okay, if they're in distress or they need assistance, you want to make sure you help them immediately. Okay. Safety precautions are important because we're looking at certain case scenarios, aseptic hand washing, which you guys will cover, and infection control. You're always going to want to make sure that you do an aseptic hand wash before and after patient contact, okay, and before and after each procedure. And also if you leave the room, okay, if you have to leave the room for a reason, you take your gloves off, you go do what you need to do, come back, and you rewash your hands and put gloves on again. Don't ever leave with gloves on your hands, okay? You're going to wear gloves if there's ever the possibility that you might be in contact with any kind of blood, body fluids, non-intact skins, or any kind of open wounds or abrasions, a moist mucous membrane, okay, and anytime you're going to handle specimens, if any kind of biopsy's been done, any kind of vaginal exam has been done, that you're going to want to make sure that you transport and package everything while wearing gloves, okay? Respiratory hygiene and cough etiquette is also important. Most places have a cough etiquette set up, and they'll ask the patient at the front desk whether or not that patient's coughing. Okay, and if they are, then they'll usually ask them to put on a mask. And so if you even have a day where you're not feeling very well or coughing a little bit, it might be a good idea for you to wear a mask to prevent exposure to the patients and yourself. Okay. Table 38.1, page 759, talks about certain case scenarios when and the type of PPE that you'd want to wear for what kind of infection and what kind of situation. So just kind of take a look over that page so you have a little bit of an idea, and it gives you sort of a general sense of what PPE is necessary for what case scenarios. Okay. Always make sure that after the patient leaves that you disinfect the table, anything that the patient may have come in contact with, counter surfaces, as well as any trays that were used. Okay. Now, preparing the patient is important. Some patients are very are apt and are used to going to the doctors, and so it isn't as big of a deal. But some people haven't been in a long time. Some people may have had a bad experience in the past, and so emotionally prepping that patient, letting them know exactly what's going to happen and what they're going to feel, and making sure that it's not medical terminology that they don't understand. You want to use simple, direct language in layperson's language so that they'll understand. Okay. Now, the bathroom situation may depend on the scenario. A lot of times it'd be preferable for them to have an empty bladder, but there's going to be a point in time where you're going to need to ask whether or not, and look at their symptoms and see as to whether or not a urinalysis is going to be necessary. If urinalysis is necessary, you could do it before the exam. You just need to know whether it's going to be a clean catch or not a clean catch. And we'll talk about that a little further when we go to diagnostic testing. Okay. Um, you may have to ask the patient to completely disrobe, and that might include bra and underwear. And so you'll have to specify that. A lot of times people just, when you tell them to get completely undressed, they don't disrobe their underwear or their bra, and you'll need to know what they're there for and then what the clinician prefers depending on the case scenario. They're going to need to be completely undressed, including bra and under, if they're going to have a pap smear and or breast exam. If it's a physical exam and it's not going to include those two things, then it's possible the clinician will let you leave the bra and underwear on. So it's important to know what you're dealing with and what the clinician wants. Okay. Be aware that modesty is an issue. Okay. Some people aren't as modest as others, but it is important to feel and sense their comfort level, and to be kind of extra cautious as far as maintaining their privacy. Some people might need more than one drape. Some of the drapes are small, and depending on the patient's body size, they might need two. And so it's important to make sure that they understand how to put the appropriate gowns on, and to make sure that they feel comfortable with it. Okay. Now the next few slides kind of goes through the positioning and draping, and I apologize, but the pictures overlapped, putting them on here. Figure 38.1 on page 760 kind of goes through these, and they're a little bit more obvious on that picture as opposed to, unfortunately, what's here. And so once again, these positions are important. It's important to know when you would put them in and what part of the physical exam you would do in each one of these positions. Certain positions you would not want to put that patient in and then let them sit there for a half an hour waiting for the clinician to come in. So make sure we're familiar with these positions. We'll go through in class how to put people in these positions. And you're going to want to know certain case scenarios. We have some that are used with people that have low back pain, or certain positions you shouldn't use with certain case scenarios like pregnancy or the elderly. And so it's going to be important to have an idea of that, know when you would use them, what you're examining, and then when you would not put the person in that particular position. And so you always want to make sure you're making the patient as comfortable as possible. We'll go through some draping, but the idea is just to make sure that we are putting them correctly in the position that's indicated. Okay, you might need to keep the patient warm too, because usually rooms are kept at 68 degrees, and some people get quite cold with that. Okay, so the three that are listed here is the sitting position, the supine or recumbent. Those are two words are kind of synonymous. And then dorsal recumbent, which we can't see here, which is basically laying in the recumbent position, but the knees are elevated to about 60 to 90 degrees. Okay, and that actually helps to decrease back pain. Okay, if someone has low back pain, it can be difficult to lay completely supine. Okay, it kind of hyperextends the lower back. Now the book goes through and talks about each one of these, what you would be examining in this position, as well as certain case scenarios where you would not put people in this position. And we'll go through these in class, but if you look at like the sitting position, it says the sitting position, the patient's at the edge of the examining table without back support. You would examine the head, neck, chest, heart, back, and arms, okay, while the patient is in the sitting position. Okay, you can actually you can examine the patient's ability to fully expand the lungs, and so that's why this is an important exam for both the lungs and the cardiac, as well as the other things that were mentioned. Okay, and so that would be something that might be important to list on the test as well. Okay, if someone has a difficult time sitting upright without support, then you would want to put them in something modified and not this position. Okay, sometimes the elderly have a difficult time sitting up for this length of time. Okay. Then as we go down and we go to the supine or recumbent, but like I said, both of those are the same thing. That's when you're lying flat with the hands to the side. And so things that we would be looking for here, all right, would be to examine. You can also re-examine the head, the neck, the chest, the heart, the abdomen, the arms, and the legs when the patient is in this position. It isn't listed in the book, but you can also do a breast exam in this position as well. So you might lift the back a little bit, and we'll talk about that when we get to, I think Fowler's is in here. We'll talk about that when we get to Fowler's. But the supine recumbent is common. If somebody has low back pain, you would want to put them in the dorsal recumbent, which is putting something underneath their legs or lifting their legs up. You could put a pillow underneath there. This position may not be suitable for patients that are short of breath. Someone with COPD or CHF may not do well in this position because they can't breathe. Or if someone is morbidly obese, or a pregnant patient, okay, might not do well in this position, especially in the later stages. So those would be case scenarios where you might not be able to put them in the supine. Okay. Now if we go to the next few that are over here, we have 4 listed here, and unfortunately these 2 are not. The lithotomy and Sims is kind of blocked here. And so we'll talk about these 4 briefly. Okay, the lithotomy position is used generally when you're doing a female genital exam. This exam, obviously this position or something similar would be during birth as well, but lithotomy is prototypical position for doing a pelvic exam, pap smear. Okay. This can be one of the more sensitive positions, and so making sure the female is covered appropriately They still have to be able to do the exam, but you definitely would not want to put a patient in this position if they're there for a pap smear and not know how long it's going to be for the physician to come in. You'd want to wait and help assist this patient and put them in this position for the least amount of time. Okay. A patient that has severe arthritis or joint deformities in the hips or knees might have a difficult time with this, as sometimes the elderly can too. Some people get, there's a prototypical common thing that happens at putting women in this position, they get leg cramps. And so sometimes you have to modify it and keep the tray pulled out, or do something a little bit modified with this. And I'll show you a few of the modifications when we're in class. Okay. And then if we go to Fowler's, this is Fowler's right here, where you're kind of laying, you got the back raised anywhere between 40 to 60 degrees. And so this particular angle can be used to examine the head, neck, and the chest areas. Generally, you're going to be draped from the neck down if you're in this position. It is one of the better positions for somebody that is experiencing shortness of breath. So if you need to do the body parts that we talked about, but they have CHF or they have trouble breathing with laying down, this would be an alternative. Would be in a Fowler's position, okay, or even a low back injury as opposed to doing dorsal recumbent. Sometimes elevating the back a little bit can help, okay. Over two, these guys are superimposed on each other. The one on top here is prone. The prone position is when the patient is lying flat on the table, basically face down. You want to turn their neck to one side, and prototypically you're going to put their hands either bent up, elbows above their head, or they could, if they're more comfortable, they could do it down by their side. Okay. In this position, you're going to be examining usually the back, neck, or some sort of musculoskeletal exam. You certainly would not want to put a pregnant patient in their third trimester in this position. You have to find some way to modify it, as well as obese patients and then respiratory difficulties in the elderly. So there are 4 different patient types that might not do well in the prone position. Okay. I know we can't see the SIMS, which is underneath here, but the SIMS is listed. I think it's image G on page 760. And the Sims position is better if the patient lies on their left side. I know, once again, you can't see it here. Their left leg is going to be slightly bent. The left arm is placed behind the back, so the patient's weight is resting primarily on the front part of the chest. The right knee is bent and raised towards the chest, and the right arm is bent toward the head. Okay. This position is going to be primarily used for rectal exams, okay, anal or rectal exams, or perineal. The book says perineal and pelvic exams. I've never done perineal pelvic exams in this position. It is listed there, but it's primarily rectal exams. If you were going to do a rectal temperature or have to give an enema, that would be an ideal position to use. Someone with joint deformities and or hip or knee issues might have difficulty with position depending on which knee is bothering them. So you can sometimes use the lithotomy. The SIMS is an option, and we'll talk about a couple others that can be used if necessary. Okay. Now these two, the last two that are listed here, and I know they're superimposed on each other as well. The knee to elbow is also called the knee to chest. This one isn't used a lot in the clinic. There's actually a way to modify this that I'll show you in class. But this is also a position where you would be doing either a perineal or rectal exam. Once again, there are certain patients who would have difficult time assuming this position, pregnant patients, obese, or elderly. And so usually SIMS is sort of an alternative to this particular position. It's possible you might need a fenestrated drape if they were going to be doing a rectal exam. The fenestrated drape is a drape that actually has a circular hole in it that would make access for the rectal area possible. And the proctologic, which is once again kind of blocked off here. This one is more of it's also called jackknife position. It can be an alternative to knee to elbow and SIMS as well. This is more of a surgical position. If you have to do a rectal exam on a male checking for the prostate, I can show you in class an alternative to the proctologic, because most of the tables in the clinical office don't jackknife like this. Like I said, this is more of a surgical procedure, but I'll show you in class a alternative to the proctologic. Okay, but once again, these are primarily for rectal or perineal exams. So special considerations to look at are people from different cultures. It's really important to not stereotype or make judgments, because some people are not used to these kind of physical exams when they come from different countries, and it will vary from country to country. And so it's important to not get frustrated or to show frustration if they don't understand, or if they're very hesitant, or if they don't want to get undressed. It can be very difficult. And so sometimes you might have to set up a rapport first, let that patient let them build their trust. And you might not be able to do the pelvic exam and the mammogram right off the bat, or the clinical breast exam. Might have to talk to them first, build a rapport, and let that patient feel comfortable. Obviously, having information in different languages can be helpful. It doesn't always work that way, but making sure the patient fully understands. And so, a lot of times, if they know what to expect and they can get the extra privacy that they need, sometimes that will help. If they refuse a specific exam, you can't force anybody to do anything. And so, it's important to just give them understanding and patience and explain things as well as possible. And then, maybe talk to them and say, this is what we need to do, but let's do just a regular, we'll just deal with your medical problems this time, or just do a physical exam. Let's schedule another visit and maybe have you think about whether or not you want to try to, deal with the issues that maybe are a little bit more of a privacy issue, like a pap smear or breast exam. Okay. Disability, patient with disabilities, there's usually certain types of tables that actually have a pedal that will allow the table to go up and down. And so those can often be used with people with disabilities, where you can bring the table down very low. We will go through during the PT day, and you guys will learn how to transfer a patient from a wheelchair to a table. And so those patients are going to need more help. You can't just leave a patient in a wheelchair and say, okay, get undressed and the clinician will be in 5 minutes. They might need help. And so you're going to have to ask them, do you need help disrobing? Do you need help moving to the table? And then there's certain positions that they can't get into, so things will have to be modified. But you need to ask and be proactive about seeing if they actually need assistance with these things. Okay. Okay, so now we're going to look at the examination methods themselves. And although you guys aren't necessarily going through this procedure yourself, it is still very important to be familiar with what clinician is doing, what they're looking for, and what instruments are going to be needed, and what positions you may need to help aid putting that patient in. Okay, so when we look at examination methods, we're looking primarily at, oops, too far, sorry. There's 6 different exam techniques that we're going to talk about, and the acronym for it is IAPPMM. Okay, so the first thing that you're going to do, that the clinician does, is an inspection. Okay, you're going to do a complete visual exam from head to toe. Okay, from the head, face, scalp, neck, all the way down, a full skin exam. That's usually if you're at a dermatology office, that's usually the first thing that they do, is a full visual inspection, and then you'll give sort of a generalized impression of what the patient looks like. Okay, if they're normal, if their head is normal shaped and they have normal hair distribution, if they look healthy and well groomed, versus maybe somebody that looks very thin and cachectic and pale and has poor dentition. You're doing a full physical exam. Okay, you're looking at their posture, how they're sitting, their mannerisms, their hygiene, and you're going to basically look at all of these things in regard to shape, size, color, position, and symmetry. Okay, and then the idea is to note any abnormalities. That could be skin lesions, moles, scars, anything that might be out of the norm. You would want to mention in the visual, or at least address and look at in the inspection part. Then generally after the inspection, you're going to start auscultating. Now remember, auscultate means to listen, and we use the stethoscope to do that. Okay, so you're going to be listening to certain body sounds. The areas that we auscultate would be the lungs, would be the heart. You can auscultate the abdomen for bowel sounds. And then there's also something called bruits, and bruits are a high-pitched sound that can happen to arteries when they have occlusion in them from cholesterol or what have you. Okay, and so you can listen to bruits in the carotid area, and you can also listen to bruits in the renal area. And so those are a common thing that you would also auscultate for. Then we go to the two P's, palpation and percussion. And so then next we're going to palpate. And so that palpating basically just means touching. And you're going to be assessing for texture and temperature and shape depending on what body part you're looking at. There's a situation where you can actually determine or look at the presence of vibrations or movement. And we'll talk about that. It's actually called tactile fremitus when you're looking at the lungs. And then we go to percussion. And percussion is a tapping or striking on the body to hear certain sounds or to even feel vibrations. It's usually used to determine the size, location, and density of some sort of organ or structure. So you can percuss in the lungs. You can actually percuss to see if there's any fluid in there. In the lower parts of the lungs or in the lobar areas of the lungs, you can percuss the size of the heart. You can percuss the size of the liver. And so you can also percuss for solidity or solid sounding areas in the abdominal area that might indicate even constipation or some sort of tumor. So I'll go through and show you what percussion looks like. A lot of doctors skip this one, but there are certain parts of the body where it can actually give you some information. So it can be a useful tool. And then we go to the last two, which are the two M's, mensuration and manipulation. And mensuration is just the process of measuring. And not every exam will you do measuring because you've already done height and weight, but there's other mensuration might be done. If there is a mole or lesion or bruise, you would want to measure the width, the diameter of the area. If you have a breast lesion, or even just palpating a breast lump, you'll usually try to at least get an idea externally of how big that area is. That way, if it grows in size, you have something to compare it to. It's possible you might have to measure, if one side is asymmetric compared to the other, you might have to measure the diameter of that particular extremity. If someone comes in complaining of a DVT or possible deep vein thrombosis in the calf, you'd want to measure both calves. And so there are certain things to measure. A pregnant lady will measure the fundal height. And so that's another thing that can be measured as well. So we'll kind of go through and talk about the mensuration possibilities. And then manipulation is usually the end. And sometimes family practitioners will skip this, but definitely the orthopedics won't. And it's basically a systematic movement of all the patient's body parts. You're checking for not only abnormalities, but also range of motion, as well as strength and equality of strength. And so you want to make sure they have full range of motion of all of their limbs and joints, but as well as equal strength. And if one side is less than the other, that would be of significance. And a lot of times this is a time where they'll actually do reflexes as well. Okay. Now the components in the general physical exam, we will go through this in class, and I'll give you a basic overview of the order of how things are done. Generally, the first thing you're going to do, like I said before, with your inspection is going to be a general appearance and look at specific body sections for making this general appearance. Um, these physical exam components can vary from practitioner to practitioner and specialty to specialty. So even in class, when I go through this, I'll kind of go through and give you a basic general, way that I've done it and how I was taught. But once again, you might find some minor variability in this. Not everybody's going to do the exact same order, but we'll go through the standard stuff that's pretty prototypical for most clinicians. Okay. And so it's just going to be important to know pretty much the order of performing a physical exam, be familiar with the components, know what supplies and equipment are going to be used by that clinician. And once again, that will vary from clinician to clinician as well as specialty to specialty. Always try to make sure patient's modesty and comfort is dealt with and protected. Try to make sure that patient is able to stay as covered as possible. There may be scenarios where they have to uncover a little bit, but you always want to try to maintain as much of that patient's privacy as possible. So generally, we start with the general appearance. That's a general state of health, how that patient looks, if they're awake, alert, oriented, and in good visible health. Is there any distress or pain? You're going to do a full skin You're going to do a full skin check at that point. You always want to check the nails, the nail bed, and the hair. The nails can give you a lot of information, whether or not there's good capillary refill. If the nail beds have any pitting or anything in there, a number of disease processes can actually be detected by the nail beds. Hair is important too, just looking at texture, fullness, whether or not there's any alopecia or any gaps in the hairline. That's important to look at. Then you'll check the head, looking for abnormal conditions in the scalp or skin, looking for seborrhea or some people can have seborrhea or psoriasis in the hair, so that would be important to look at. You're going to be looking at the puffiness of the eyes, any abnormal growths in the head. And then we kind of start at the top and move down. We would go to the neck, checking the thyroid gland, the major vessels, which are the carotids. You can listen to carotid breweries at that point. And then you're going to do a lymph node check starting in the neck. Or actually, you can do the ears, pre and post auricular, then drop down to the neck, and then go to the clavicular and supraclavicular and infraclavicular areas. Some people at that point will do symmetry and range of motion of the neck as well, or some people will wait and do that at the end with the musculoskeletal. It kind of depends on the doctor. Then we'll go to the eyes, and you're checking for any abnormalities in the eyes. You're going to do a physical extension or a physical inspection. You're going to want to check the pupils for light response. You're going to want to check the extraocular muscles and make sure that they all move, looking for strabismus. And then you're going to want to do an ophthalmoscope exam, checking for internal structures, papilledema, anything going on with the retina. Then you're going to go to the ears, nose, and throat. Those are all kind of interconnected, so that's usually next after the eyes. Looking at the outer ears, looking at symmetry and size, making sure both auricles are even. If they lie low, that could indicate that there is a genetic issue. You're going to look for any lesions, swelling, or anything externally that's an issue. Then you're going to want to check the canals as well as the eardrums, looking for patency of the eardrum and any type of infection. Nose and sinuses, obviously anybody that has allergies would have a change in the nasal mucosa. We'll talk about that as we go through. Any tenderness in the sinus area, and usually you can palpate the maxillary sinuses as well as the frontal sinuses. And you'll go to the throat or the mouth, have them open up and say, ah, and you're looking for the overall health and hygiene in the mouth, the gum line, the teeth. Even though we're not dentists, that would still be a referral that could be made if somebody has really poor dental hygiene. And you're looking for the throat, any swelling, redness, any kind of signs of infection or anything out of the ordinary. That kind of completes the ear, nose, and throat as far as the upper from the neck up. We would then travel down and go to the chest and the lungs. You would inspect, auscultate, palpate, and percuss the front part of the chest as well as the back part or the anterior and the posterior part of the chest. Listening for anything out of the ordinary, any abnormal breath sounds, the abnormal movement of the chest. Once you've done a complete chest, front and back, then you can go to the heart. And not all people will percuss the size of the heart, but it is an option that you can do. Generally, after you've percussed, you would then auscultate for heart sounds, and then you're going to look at the rate, rhythm, intensity, and pitch, as well as looking for any murmurs in the heart. And generally, you're going to listen with both the bell and the diaphragm. Okay, and we'll kind of show the different areas of the heart when we're in class. At that point, a lot of times you've kind of completed upper part of the body while they're sitting up. At this point, you generally would lie them down and you would re-listen to the heart and percuss while the patient is lying down. You can do it in the sitting position, and then you would actually have them lie supine or semi-recumbent or in a Fowler's position. And then you would re-listen, you could re-auscultate and percuss the heart at that point. And then from there, if it's indicated and that person's going to have a breast exam done, if you have a female, you then could go through at that point and do a breast exam, doing an inspection, palpation, um, looking for any lymph nodes in the axillary area, checking the breasts, the nipples, as well as any possible masses that might be there. Then you can go down to the abdomen, same thing. You're going to do IAPP, looking for an inspection, auscultation, percussion, and palpation. And then there's different landmarks in the abdomen that can be used as far as seeing if there's any acute signs of pain. You'd have to use those specific landmarks. After the abdominal exam, if it's indicated and if it's a female, you could put the patient in the lithotomy position and go through and do a female pelvic exam. Now, a lot of times they won't do the breast and the female pelvic exam during a general physical. They'll actually schedule a separate visit for that. It just depends on the physician. But at that point, after the abdominal exam, you would then go to the genital exam and do a pap smear if it's indicated. If we have a male patient, at that point you could do a male genitalia exam. You would inspect the penis and the scrotum and the groin, looking for any hernias. That's when you could do the prototypical turn and cough, checking for any hernias in the inguinal area, instructing the patient on how to do a self genital exam or testicular exam is important. Testicular cancer is actually more common in the 18 to 34 range of males, and a lot of males don't know that. So if you have a male patient, going through and instructing them on how to do a self-testicular exam is important, because you want to catch anybody in that age range. And a lot of guys don't realize that that's the actual most common time for testicular cancer. Okay. After the testicular exam is done, if it's indicated female-wise or male-wise to do check for sexually transmitted infection, that can be done at that time. Then when we're looking at doing a digital rectal exam, the acronym for that is DRE. If you're dealing with a female over 50, they'll usually do a rectal exam. Sometimes they'll even do the occult blood for occult blood testing at that point, and then send the patient home with further testing. For males, when you're over 40, they need to check for prostate size and consistency, and so that can be done at that area as well. Now, to be honest with you, they do list the musculoskeletal exam next. If a rectal exam is going to be done, typically they would wait and do that last, and then do the musculoskeletal. And so once again, you have to kind of deal with the clinician and who you're working with. But prototypically, even though I think the book lists the rectal exam in this order, a musculoskeletal would probably be done first, and then they would bypass and then go to the rectal exam. Okay, musculoskeletal exam. If you have a pediatric patient, generally in that age range 10 to 12, for both males and females, they'll actually check for scoliosis. That's when they have them bend over straight and at their waist and touch their toes, and they have to look for the curvature of the spine and the lifting of a scapula to assess for scoliosis. They might assess for gait too if you're looking at a patient that's elderly that might be needing to be evaluated for joint issues, arthritis, and or maybe even Parkinson's. They will do a gait evaluation. They will usually check range of motion of all the extremities to see if patients have limitation or pain with range of motion. Body measurements can be done at that time depending on the case scenario, and then obviously it would be important to note any lesions or deformities. And then you would also want to check for circulation in the distal extremities, so radial, ulnar pulse, capillary refill, as well as dorsalis pedis and anterior dorsalis pedis and posterior tibialis pulses to make sure you have good circulation in the lower extremities. Last but not least, we can throw the neurologic exam in there. And once again, these are all things that can be done. You may not do a full neurologic exam on everyone. Reflexes are usually done, and there's about 6 or 7 different reflexes in different parts of the body that can be done. The prototypical one is the patellar, but there's a few others that you can do, and depending on the scenario, they may do more. They may do all of them or just 1 or 2. Mental status and emotional status can be done if you think we're dealing with something like anxiety, depression, or if you're dealing with a geriatric patient that might have an altered mental status, Parkinson's, Alzheimer's. Doing a mental and emotional status is important. Same thing with sensory and motor functions. A lot of times they'll check for sensation in the extremities as well as motor function and strength. Frequently, when you're dealing with pediatrics, they will do not only developmental exams, behavioral exams, as well as an intellectual assessment in children. And then when you're dealing with the elderly, you have to always think about memory issues and mental status. And so these may be also done in an elderly patient to make sure that they don't have the beginning onset of Alzheimer's or something else. Okay. After all the exam is over, and once again, that's pretty much a complete physical exam. That wouldn't be a focused problem with something that would be when you've performed a complete physical exam. You're always going to want to help the patient to a sitting position. Chances are they may have been laying down at some point, and so if you're there, typically, if I'm the clinician, I help them up, but it might be a case scenario where the clinician turns around to do something, take his gloves off, wash his hands, and you might need to assist the patient. So in any care, look where the patient's at and help them, assist them to sit if necessary, okay? You might need to give them Kleenex if they've had a vaginal exam or a rectal exam. Generally, KY jelly has been used, and so they're going to need, you're going to have to hand them some Kleenex and give them some time to kind of clean themselves up, okay? You're going to allow the patient to dress most of the time. There may be a few case scenarios where this doesn't happen, where you have to, maybe they had a wound check done or a lesion removed. You might have to dress that first before the patient gets dressed. But prototypically, you're going to want to ask them if they need help getting dressed. If they don't, then give them some time to do that. You have to look at what has been written in the plan as far as performing any additional tests or procedures. You'll need to take a look at that and see what the clinician has ordered. And then you're always going to go through and give the patient discharge papers and then go through the patient education. So what might happen prior, if there's a case scenario, sometimes prior to dressing, if somebody had a musculoskeletal issue, generally this is more significant in a physical therapy environment or an ortho environment, but you might have to apply cold or heat therapy depending on what that patient was there for. Generally, that's not going to happen in a physical exam. Same thing with applying bandages. That would be usually a case scenario where somebody had a wound or a lesion dealt with and isn't prototypically going to be done in a physical exam, but it might be done in a focused problem that they came in for. Collecting specimens appropriately, making sure that specimens have appropriate stickers, and then wherever that site was from, if it's a biopsy site, you'd want to write where the biopsy was, right forearm, skin lesion, right forearm. If it's a vaginal specimen, you'd want to write vaginal discharge or chlamydia. Whatever the case would be, you'd want to make sure you label what your specimen is. And there's case scenarios where some medications might need to be administered before the patient gets dressed. Others, most of them, afterwards is okay. But just know your facility. Okay. After the patient gets dressed, there may be things that can be done. Urine reagent strips, checking for things, pulmonary function testing, maybe eye or ear irrigation, depending on, or medication administration. There's other things that fall underneath this category, but just be aware that you'd want to get them dressed before doing these things. The thing to know, though, is when to empty the bladder and when not to. The key is if the patient has urinary symptoms, you might have to send their urine for analysis. If you have them go to the bathroom before the exam and then they need urine and then they can't go, it can cause a problem. So you always want to try to be proactive and get the appropriate urine specimen ahead of time. Okay. This is a real big one, patient education. This is a huge part of what the medical assistants do during the checkout process. So things that you're going to look for are risk factors for disease, okay? Looking to see whether or not medication needs to either be administered or called to the pharmacy. Now with EHR, a lot of things are e-rexed over, but you're going to want to make sure you let them know, hey, the doctor is starting you on a new medication. If it's short term, you'd say this is for 10 days or whatever it is. If it's a new long-term medication, generally you're going to have to start them on it, and then prototypically you would bring them back in for a follow-up depending on what the clinician says. So just make sure you always highlight any new medications, or if a dosage change dose has been changed, or you'd want to call attention to that as well. Okay. And then any diagnostic techniques, you'd want to say the doctor's ordered a mammogram or a chest x-ray or an MRI. We're going to call, give them the number that they need to call, or, help aid them or tell them that you will call and make the appointment. And so you always want to make sure you're proactive with any diagnostic techniques or tests that are going to be ordered. Always make sure you use appropriate language for that particular patient, whatever they're, kind of assessing where their level is and making sure that you speak in a language that they understand. Always give them verbal instructions, but back it up with written instructions. And the problem too is that if someone doesn't know how to read, that can be a problem. So you might have to write a phone number down, and you might have to go through it a couple of times to make sure that the patient understands the directions before they leave. Okay. And then always double check for follow-up. Okay. Many times after somebody's had a physical exam, they may bring them in to go over all their lab results if they've had blood work done. If they had to order imaging, they'll bring them back in a week or two, depending on the case scenario. If it's a focus problem with like a wound check, they'll usually bring them back in 2 or 3 days. Sometimes they'll even give them emergency room precautions if like someone had a urinary tract infection or a wound infection for the ER if things don't get better. And then as well as referrals to outside places. If someone is being referred to a specialist, you're going to want to let them know that that referral's been placed and that someone will call them. And if they don't hear anything, that they should call the clinic back so they can get it straightened out. Okay. There might be case scenarios with geriatric patients where you're having to help plan home nursing care or hospice care, or even just a skilled nursing visit, depending on the patient. And so that is something that you have to look at and deal with in the follow-up. And then giving the patient a number to call if they have any questions or issues. They always need to be able to call back in case they don't understand something. Okay. Okay, so we covered quite a bit in this chapter. We talked about a physical exam, the components, the different parts of the physical exam, what the exam's looking for, and then basically what each individual body organ system, things that clinicians are looking for, importance of being able for the medical assistant to recognize those things so that you are, on the same wavelength and what's being addressed, so that if the patient has any questions, you can answer those questions to the best of your ability. Okay. There's a little section in there talked about the hand hygiene. Please make sure you go through that table that talks about that. Okay. We talked about the 6 examination methods, all the way from the head all the way down to the neurologic system. So we'll go through that in class as well. I really want you to focus in on the plan, the follow-up care, and the patient education. That's a huge part of what the medical assistant has to do. You guys do the interview in the beginning, and then you have to check them out and make sure they know what's going on. And so please make sure you go through that part and realize what an important aspect that is to the patient care. Okay? So that ends us for this chapter, and we'll go through a lot of this stuff in class. And okay, chapter 38, signing out.